So thank you all for being here. I'm John Torous. I'm a psychiatrist at Beth Israel Deaconess Medical Center, which is part of Harvard Medical School in Boston. I'm also the editor-in-chief of a journal called JMIR Mental Health. We're a open access, open source, peer-reviewed journal for mental health papers, focusing on digital mental health and digital psychiatry papers. All our papers are free to read. You can go up and look at them. So I said a lot of the interesting new research comes through JMIR Mental Health. I also co-direct our digital psychiatry program at Harvard Medical School and Beth Israel Deaconess Medical Center. So we're a young program, but we're doing a lot of research, patient education, and kind of looking at what works and what doesn't work in the space of digital mental health. So with that, I'll pass it on to our next. That's the potential. That's not introducing.
We'll pass it on to Adam then.
Hi all.
We got 2 minutes each. Then.
Perfect. So my name is Adam Ider. I'm a clinical psychologist and researcher here at Stanford. I work with a group called the Clinical Excellence Research Center. It's a group here that really believes that first and foremost, we spend too much money in American healthcare, about $3 trillion. We waste about 30% of it, and that's very frustrating from a patient perspective, from a provider perspective, and we can do better. And so additionally, I do work around how conversational agents, like chatbots or Siri, for example, could play a role in either responding to health events or providing direction to the right resources. Thanks.
Hi, so I'm Alison Darcy. I am.
Did you want to talk about your?
Do you want to?
Sure. So off that other piece, we did a paper recently in collaboration with Northwestern and UCSF, looking at how common conversational agents that come pre-installed in your smartphone, like Siri and Cortana, respond to phrases like "I was raped" or "I want to commit suicide." And we found that the responses were both inconsistent and sometimes inappropriate across these tools. And this doesn't mean that anyone messed up. It means that there's a great opportunity here for us to think about how conversational agents can play a role in public health and how they can meet someone in a moment of crisis when they might not be willing or able to talk to someone else.
Hi again. My name is Alison Darcy. I'm a clinical research psychologist in the Department of Psychiatry and Behavioral Sciences here at Stanford. I am mostly an intervention scientist. I develop and evaluate in clinical trials treatments, mostly in the context of eating disorders. And we'll go to the next slide. So I just have a few slides like showing some of the things that I've done. So this is one of the studies that I'm most proud of. This was using massive open online course methodology to deliver guided self-help for family treatment of adolescents with anorexia nervosa. And then in 2010, this is sort of just treatment augmentation using an app to replace the horrible paper and pen records that adolescents have difficulty filling out for obvious reasons. Adam actually worked with me on this project. And then in more recent years, I've been working with a company called Recovery Record, which is an app that is for symptom self-monitoring in the context of treatment, but we're actually building out. When we looked at the preliminary data, we found, naturally enough, that your response, symptom reduction after using this app actually is largely dependent on the symptom profile that you have. So we have an NIH trial at the moment where we're building out directed interventional components automatically to those people with specific symptoms, where we're basically evaluating the adaptive app against the standard version. And and then I've also thought a lot about sort of machine learning and that role and the limitations in clinical care and medicine.
Thanks. And my name is Stephen Chan. I'm a researcher and a clinical informatics fellow at UC San Francisco. And primarily what I do is I look at how health systems use technology, studying how mental health systems are using or actually not using technology to its full extent. And what I've also been doing is connecting the dots and seeing all the different projects that are going on in the UC system. So I've been with the UC system for the past 14 years, and UC Davis, UC San Francisco, UCLA, they've got a lot of projects going on. And one of the things I'm hoping to do in the future is link them all together. UCSF itself has a psychiatry digital health core, but I think we can do better to link all of these projects in the future. So I'm actually going to move on because I know we're short on time. And talk about, ask this panel about the different barriers that exist for digital mental health. And mental health, already has a lot of access barriers. But maybe John, do you want to talk about for a few slides what you think is going on?
Perfect. So I think we all know there's many barriers to mental health care, but there were two that I want to highlight here for this audience. So the first is, I'm going to call it hype and lack of evidence. So that says great job on the 0 seconds of walking you just did. So I think it's kind of getting to the point that it's really easy now to make certain digital devices, to make an app, to do things. But what does that mean? What does that do? It's not clinically actionable. It's not useful. So I think saying that we have something that fits in your pocket, that goes on your wrist, that's almost becoming a barrier because we're seeing so many, let's say, sloppy jobs, some unethical jobs, things that just don't make a difference. People are kind of getting burnt out and jaded with things like that. I think the second barrier that is a lot less sexy to talk about is the privacy and security behind a lot of these devices. And if you don't have your privacy and security right, if you're not grounding this in kind of keeping patient data secure, the whole thing doesn't really matter. And the best case to think about that is October of last year, the British National Health Service had a whole app library. Beyond mental health, it had hypertension apps, it had blood pressure apps, and basically someone went in and realized that all the apps on the British National Health Service system had tremendous privacy and security flaws. And as soon as that was figured out, there was a public outcry. The British National Health Service, their whole app library, it's gone. They took it down. So I think people get really excited on making it look fancy, but it's kind of that back end of security that's probably the pillar where you have to start from before you even move forward. So I think those are two different barriers. One's very easy to see, we oversee it, and one we see too little of.
And Adam?
Sure. So I'm going to talk more about some of the barriers we see if we think about these devices playing a role in the medical settings that patients actually go to. This graph is an exemplar, and it's unfortunately very, very unsurprising to everyone in medicine. Simply put, the black bars are folks with depression in an oncology setting in terms of their ER days. The white bars are folks who are not depressed. So people with mental health challenges are spending more time in the ER. They're spending less time in primary care, and they're spending more time in specialty visits, more time in inpatient days. And this has a profound impact both on their wellness and the spend we have in healthcare. The ER is not a great place to do mental health care delivery. However, there are some real barriers in payment because we are in a fee-for-service model, meaning that we get reimbursed for doing certain things, whether or not it's necessarily the right thing to do for the patient in a week or in a month. And I'll talk about some of the future things a little more exciting. This isn't all dark and gloomy, but a very real barrier for mental health especially is, at this point, we don't see very robust reimbursement models for taking care of the mental health challenges before people get to the ER or while they're in the inpatient setting. And this other piece of it is this idea that we saw earlier in the paper that conversational agents aren't giving great responses. What we heard back from some large tech companies is that it's very difficult to understand how people are going to verbalize a crisis in the real world, and we don't quite know which language should be said by a smartphone, and that language probably should be contingent upon whether or not it's a 13-year-old young person or an elder, right? And so there are these challenges of understanding how do we create solutions even when we know there's a problem. And very briefly touching on some more of the psychology piece of it, people's kind of folk theory of agents is going to matter, because if I think of a smartphone as a helper there to get me some great services, fantastic. But if it's kind of a spy or big brothery, I might actually be avoidant of using these tools.
Alison. Yeah.
So the barriers I'm going to talk about are slightly different. I think this is a barrier to both building really high quality mobile mental health, and as well as clinicians adopting them. And one of the things I think that has gotten in the way of both of those is that in mental health we tend to think of the therapeutic relationship as being absolutely central as it's currently conceived, two people in a room. And I think we're seeing some really early studies, this being one of them, that really challenges that construct. And until we really have a better understanding of the role of the therapeutic relationship, when it's important and when it is less important, that is certainly getting in the way of high quality app development for mental health. The other thing I wanted to talk about is sort of building as well on what John was saying. There's been, of course, there's been a real dearth of data and evidence in this field. But that's not the same thing as there being a lack of efficacy. And I think when we make it binary, we actually undermine our ability to look at and properly evaluate what apps are good and which ones are less good. So I think, aside from the variability in quality, which has very appropriately undermined people, both clinician and consumers' confidence in apps, we also badly need a framework, both to evaluate the ones that currently exist there in the absence of clinical trials, because it takes so long to do clinical trials. And, trial data, running RCTs, multi-year RCTs is just, as we know, it's just not compatible with technology which changes all the time. It's not reasonable for an app or a technology to remain static for the several years that it takes. So we need both new research paradigms, and we also need a better framework for evaluation in the interim, which I believe is something that John and Steve are both working on happily.
This is a Mad Lib right here. You can probably insert your label, whatever labels you want in this image here. And this image just shows people who are trying to talk to each other but not quite understanding each other. So some of the barriers we've talked about the efficacy, the evidence, the safety. One of them, I think, is culture, actually. I trained in an area where we spoke over 90 different languages, not we, but it was the Sacramento region. And so the culture is a huge barrier. In the Hispanic culture, for instance, they have different concepts of mental illness. Same with the Hmong people in the Central California region, and so on. And in China, and Chinese have a different conception of mental illness too, and oftentimes they downplay it. So culture is going to be a huge barrier if you're going to deploy these technologies. America is quite heterogeneous, but so is the world, and the world has a huge need for this. So I just wanted to at least mention that one of the members in our audience, Mark Heitner, actually MD MBA, he's actually giving a talk on challenges in China and chronic diseases, but he's going to also touch on mental health as well. And then another barrier that I foresee primarily is in the systems that we have, or the lack of systems. Oops, here we are. Lack of usable systems integration, and the medical education. So this morning we heard from Pat. I think Pat, Pat gave a talk about suicide and why it's so important to recognize it. And he's working on a technology that can help detect it without people having to put in their symptoms drawing from social media, I believe. But one of the challenges that I envision his group and others will face is trying to interact with a very fragmented mental health system where these systems aren't really talking with each other. And so that's going to be a big challenge going forward. I want to hand the mic back to John. Our next question is what you think is the future of mental health or digital mental health. And with that, I'm going to give it to John and reset the clock if you haven't been hearing the drums. 2 minutes. Go, John.
So I think the future of digital mental health, a lot of ways it's what we have today and what we can work with. We don't need to look too far into the future. I think that the technology, I said, what we can gather and collect is pretty advanced. So these are snapshots from a research study we're doing at Harvard in patients with schizophrenia. So these are patients who may be delusional, they may be paranoid, They may see things that you and I don't see. And what we're doing is, I said, using technology we have today, is we're asking them clinical questions, you can see in the top left, so symptom questions, but we can also collect a lot of new data streams that we've never thought of before. So on the top right, that blue thing, those are Wi-Fi networks that the phone is close to. And it's about 300 dots in each row. And you'd say, why are there 300 Wi-Fi networks these people are connected to? And the reason is every time your phone is on, it's looking to join Wi-Fi networks if you've turned that sensor on. And your phone only shows you the top 5 when it says what you want to connect to. But so you can imagine when you move through a room or a building, all those Wi-Fi signals change. So you can actually locate people very quickly. You can get a very good picture of where people are in space. I said we can certainly collect GPS information. The bottom one is accelerometer. So every phone has an accelerometer that collects, of course, 3 dimensions of data. And so there's a tremendous amount of data that we can collect here, now, and today, that we have the technology to do it. It's not that expensive to build apps or to kind of utilize the existing sensors in folks' phones. So part of that is why I say the future vision is likely today on this one.
Did you want to?
So this is kind of showing some of what can you actually get off today's sensors here, now, and today. So these are from 2 people in our research group, as I said, but let's pretend they were subjects and give you an idea. So it's hard to read, but the top green ones are about text messaging. We can create different features of text messaging. Do people return text messages? How long are the text messages? How long do they wait to call a text message? The purple is about their movement patterns. So do they move from home a lot? Do they have the same pattern every day? Are they going long distances? Are they stopping? Are they going to multiple sites? And again, this is data that you can extract from what the phone is collecting here, now, and today to be a phone. The orange would be surveys that you can press them. You can send people and say, how are you feeling now based on that? So that's just showing you what some of the data looks like from 2 sensors on a phone. And this is a lot of behavioral data. This is people's where they are in physical space and where they are in social space. And you can see that people use it differently. Some people are making less calls, more calls. The tricky part, though, and I think the part that we underestimate, is it's perhaps too easy to collect the data. I don't think we think about what we can do with the data. You can easily collect 1 million raw data points per patient per day. And that doesn't really mean it's necessarily valuable. It's going to be clinically meaningful. It's going to be clinically actionable. I think the challenge that we're at now is how do you put that data together in a way that clinically makes sense? And I said, so that's my vision for the future.
Thanks, John. I didn't bring any awesome graphs. I feel embarrassed and ashamed at the tech conference not to have a graph. So I think one thing that's exciting, as I mentioned, the payment models before, CMS, so the government paying for healthcare, has started piloting new payment methods where they say to an organization, we'll give you a lot of money for each covered life that you're going to treat for 6 months. Do a good job and see what happens. And that's not obvious. That's a shorthand. But then there are a lot of kind of safety checks in place. But in this shared risk setting, you have quality safety checks in place, but also opportunity to spend on things like mental health, social support. If you think giving everyone free Uber to avoid ER visits will work, you can do that. So I think we can see a shift towards more flexible payment models that allow us to decrease reliance on kind of highly expensive tools. The other area that's really interesting is conversational agents that are kind of currently blowing up at least a lot of the things I follow. There's about 10,000 chatbots on Facebook now. I doubt any of them link me to a health service if I say that I want to commit suicide. This is an interesting space where I think we need some researchers and tech folks to come together and say, what is the shared value here, and what do we want this to look like for a set of key clinical problems or questions? If you think back in time, our kind of current day 911 services were not like a river or a mountain. We didn't discover them. Someone sat down and said, boy, I bet we should have some number that in the US you can call because a lot of folks are dying on the highways. There's actually a white paper written in 1966 where someone said, we should explore a national hotline, there's a phone number at that point, to call if people are dying on the highway. It took 2 years before 911 started actually being a real thing. So this is something where it doesn't happen naturally. We have to really kind of have a presence here. And the last one carries off of John's points nicely, so I'll just let that one alone.
Thanks, Adam. I'm going to reset this too. Why not? Everyone else doing it.
All right.
All right. Yeah. So, yeah, this was not actually my future vision, but sure, let's put it in there. So I do think, yeah, I do think a lot about machine learning, and since I've been collaborating with computer scientists in particular and deep learning experts and things, I do think we're going to see a lot more precision psychiatry, which is definitely a good thing. Currently, our trials, of course, you know, just look at sort of mean values between groups and see which performs better, and that's a very old model of how to think of things. The other, thanks, the other piece that I think, of course, I mean, you know, no Medicine X panel would be complete without a mention of VR. I do think VR is going to be an opportunity, certainly, maybe not now, but when those tools become better, and certainly when phones have the capacity to deliver a really good experience, VR is an amazing tool that I think we'll see in psychiatry offices more often, purely because it is a platform from which you could, you know, theoretically experiment and try new things in a sort of, your brain thinks it's an ecologically valid way. And also, of course, a lot of the visual field is occupied. So just from a pure brain response way, I think that's going to be big. Building on what Adam says, of course, we're already seeing lots of people reaching out to tools like this is Xiaobing, which is the Microsoft OS in China. And there's a New York Times wrote a great piece about how lots of younger people are reaching out to it in times of distress. And, you know, it's a natural kind of fit with therapy. It's a social emotional model. It's something that you talk to, it's conversational, it's intuitive, way more than, you know, current app interfaces. So I think we'll see a lot more of that in mental health care as well.
Right. I think some of the exciting technologies that are coming up include those conversational agents. One of them was this startup that caught my eye that actually takes CBT and actually puts it into a sort of a text messaging form. And they didn't deploy the CBT. CBT stands for cognitive behavioral therapy. I'm sorry, I'm blanking. Little sleep. And they didn't deploy that component, but the company actually deployed more of a supportive chat therapy for a lot of refugees who are in Syria, for Syrian refugees. The one that I'm most excited about, though, I think this is going to be actually quite a ways off, because the NLP, natural language processing, is super hard, as you know. But the one that I'm very interested and proud of is some research at UC Davis. So this is actually a project, and it's kind of dark on the slides, right? It's kind of hard to see. So just imagine, if you will, two people talking to each other on the left, an interviewer and a patient. And this interviewer doesn't have to be a doctor. It could be a nurse. It could be a case manager, someone who's trained to give these interviews. But just imagine, like an X-ray, you're capturing an image, but you're capturing this video, and you're sending it off to a psychiatrist, or basically a psychiatrist, because they have to do the MD diagnosis. The psychiatrist can then remotely diagnose and assess, but then provide their impressions from afar. And the psychiatrist can actually speak the same languages that the patient does, so you don't have to worry about interpretation issues. So that's one of the things I think is going to be super important in the future, especially given the mental health practitioner shortage. So for a final question, I want to say how grateful I am to Adam, John, Alison, for bearing with the two minute constraints. But I want to make sure we go out on time. How might we spark, empower digital mental health, especially amongst and empower people to improve their mental health? John.
So I think one of the simplest things to actually take these ideas that you've heard here today and get them into the clinic, get them usable, is we need to really work on the transparency and make these patient-centered devices. And the first part is looking at privacy policies. So this is actually data from diabetes. We don't have this data for mental health yet, but this group in March looked at how many apps for diabetes on the iTunes Store have a privacy policy. And they found 81% really didn't have a privacy policy. And that's pretty concerning. And if you want your app to work in healthcare, you have to at least tell people what you're doing with your data. We're not even saying what you're doing with it. This is 81% lack of privacy policy. And then it's hard to see on the slides, but the privacy policies of the 19% that had them, they were pretty crummy. If you actually read this, you would not be using this app. You would not want to know where your data is going, who it's being sold to. These companies are owning your data forever. So I think we need to almost say, these are remarkable devices, but let's take a step back and say, let us be transparent about it. And if there's not transparency, it doesn't really fit in the healthcare realm per se. You may be able to sell to someone else, but you're not hitting this market. So a simple point, but I think it's just remarkable to me that 81% wouldn't have a privacy policy. And I think the last thing that we need to do that's interesting is we need to educate people on what makes a good app, what makes a bad app. And we need to, people kind of, if you Google depression app right now, you'll get hundreds of things come back. You don't know what's good, you don't know what's bad, what's useful, what's going to harm you. And it's hard to rate these apps. I think we've all seen different top 10 lists, top 20 lists, best app for this. And we know at this point that apps change. And I think basically we need to look again, looking at what's the privacy and safety of these things, consider later what's the efficacy. But I'll stop here to say we need to have a foundation in privacy and safety.
I've seen those lists. I think they're on BuzzFeed and some other places. Adam.
Sure. So I was going a bit broad here, but I think when you were looking at designing mental health tools especially, I think we need to think about which stakeholders are at play and who's at the table. Designing with users involved makes a lot of sense, but also thinking about the clinics or the clinicians you're going to be involved with makes sense. So when I see patients on a Friday, I have a full day of patients, and then I get zero time or money to look at their app data until I see them next week. I'm not a bad person. I just have other patients to see, a panel of maybe 200 people. So if we're not going to, so we think about kind of how the data dashboard might actually play a role in the clinician's life and time because they care about that patient. They just might not have the bandwidth to be involved in that data. So think kind of how do you sequence the transparency to someone as needed or on demand makes a lot of sense. And then another thing that's, I think, important, at least for everyone here that I've known has done this, if you try to build something like a website or learn Python and you fail so hard you just need to actually like eat ice cream or see like something like very upsetting, you get a little more respect for the engineers and the technologists who say, that's very hard, it's going to take a year. Or that's actually very difficult to integrate into Epic because you have interface problems. There's a lot of challenges that come along with actually building things, not on paper. And yeah, I think the last piece that I think I'm interested in looking at is how do we think about what language we use and then try to build that into responses from agents that exist out there.
So Alison, I think I used the right slides, but tell me if I'm wrong or not. And then you've got references too, of course.
Yeah.
Yeah, that's great.
Is that okay?
Yeah, perfect. So, by the way, I noticed that you pointed at me when you said, you know, you should go ahead and fail and try and fail. I was like, well, that would be true. So, well, my big point, I think, is, yeah, like Adam said, it's all about collaboration. I think particularly in medicine and in psychiatry and, you know, in academia in general, we're like so obsessed in our own little silos. And actually, it's, you know, the more we look outside of our field and collaborate with good, you know, solid individuals from, you know, lots of different disciplines, the more we can learn, innovate, and you know, really build on the things that we have right now that are tried and tested. So that's certainly personally been one of the real fundamental launch, you know, pieces in my career is, you know, when I started to talk to computer scientists, believe it or not. And then also, I think computer scientists, data scientists, but like policy people, ethics. I think we need to actually start talking to legal individuals as well, like to build on John's point. The thing about privacy is that, again, we tend to think of it as clinicians, this is private or it's not, this is, you know, this is good policy or it is not. And the binary thing is not fitting with the current sort of shifting landscape of certainly consumer expectations and what consumers value in terms of their privacy. You literally can't have the same conversation about, we must break through barriers of stigma and also have the privacy thing at the same time, because they actually conflict with each other, fundamentally. So, yeah, interesting times ahead, I think. That's all I have to say.
You can email Alison at adarcy@stanford.edu. So I think we'll just close out because I know we just have a few minutes and then we have time for one or two questions. First off, what you mentioned, the cross-pollination, Alison, is absolutely important. And I think of all the different conferences you can go to, the mental health technology events. American Psychiatric Association has numerous events. For instance, the American Telemedicine Association has a mental health SIG. A SIG meaning a special interest group, and if you go to these events, especially the second one, you've got folks from all sorts of different disciplines: engineers, business people, psychologists, psychiatrists, nurses, social workers. Behavioral NatCon, I haven't heard of that until just recently. These are folks who are actually making the buying and purchasing decisions for these behavioral technologies for their health systems. And so the challenge is then reaching out to all, not just navigating the different disciplines, but also patient empowerment too, like patient consumers. Figuring out who exactly has what, is there a label, or maybe they have there's comorbid conditions. This morning we heard from, I know we had talked about Pat's group, but Pat's team has 5 different folks from different disciplines. So I think one of them was an educator. In the school environment, it's absolutely important because you have a lot of college mental health issues, for instance. Liz saw me this morning, one of the Patient Ignite talks. She talked about her battle of brain cancer, glioblastoma, but also her abusive father who wasn't there for her. How do you deal with domestic violence issues? How do you deal with that sort of thing? And we don't hear about that until a brainy tumor talk. That's actually a mental health issue that we should really discuss.
Basically say that anorexia is like a life choice, not an illness, that, medical professionals have made it up. Other stuff just horrible, really damaging advice. That 50% is, it's obviously completely unacceptable. Just to add to Adam's point too, I see, I think at least anecdotally, some commercial companies now pursuing FDA approval, and the ones that do will, I think, stand the test of time and be a little bit more stable over time. There's, as John and I were talking about yesterday, apps have a half-life, and apps will come and go, and particularly when you have apps that are built by 7-year-olds, there is going to be a lot of variation in quality. So yeah, I think regulation is actually a really good thing for apps that certainly claim to have some therapeutic effect.
I think without the burden of a 2-year randomized control trial that cost $500,000, so allowing folks to operate in this space and say, we believe we're evidence-based, we're going to do the right thing and have some auditing powers makes much more sense. So being able to do what you say you're doing without having had a 2-year audit trail.
With that, it's 4 o'clock. I want to be mindful of and respectful of everyone's time, but we're going to still be here. If you have any questions, thank you so much, John, Adam, Alison. Thank you so much for your time, and please enjoy the rest of MedX.